So moving on here to talk about hypertensive disorders. So as I said, you could have hypertension prior to pregnancy, or this could be something that develops during the pregnancy. Preeclampsia is a pretty common complication, unfortunately, of someone with hypertension. And so this could be, again, pregnancy induced, or it could be that you already had the hypertension and this develops or worsens throughout the pregnancy. Generally, if it's pregnancy induced, it will start to develop after the 20th week of gestation. So signs and symptoms include severe hypertension, severe or persistent headache, visual abnormalities, and swelling in the hands and feet, and also anxiety for the mom. So preeclampsia, like we said, is that increase in blood pressure causing these additional complications. Most likely these will be identified by your obstetrician, and you will be closely monitored, maybe even put on bed rest. We call that preeclampsia. Now, when we move from preeclampsia to eclampsia is because of seizures. So it's very important that you know for testing purposes that the movement from preeclampsia to eclampsia happens when the patient starts seizing. And the definitive treatment for this is delivery of the fetus. Now, this could be treated with medication by a doctor or by your ALS personnel if you have a pregnant patient who is seizing. But again, the definitive treatment for this is going to be delivery of the baby. That should be what resolves the crisis. During the active seizure, you want to lie the patient on their left side. That's very important. Maintain a patent airway. Administer oxygen if you can. And if they vomit, of course, suction the airway. We do need to have ALS here to assist us, and then provide rapid transport to an appropriate facility. And that needs to be somewhere where they can deliver the baby. So not all hospitals have labor and deliveries or operating rooms if a C-section is needed. So we need to take the patient to an appropriate facility. So transporting the patient on their left side can help prevent supine hypotensive syndrome. And this is caused by compression of the descending aorta and the inferior vena cava by the pregnant uterus when the patient is lying supine. And so again, this doesn't just apply to preeclampsia or eclampsia. It just is anytime that you're transporting a pregnant patient, especially if it's after the 20th week. You definitely don't want to have them lying flat on their back. That increased weight pushing on those blood vessels could be very dangerous. So transporting them on their left side is important. And you can even do this if the patient is backboarded. You can just have them secured down and then tilt the entire board over onto its left side and prop it up with pillows or blankets. So looking here at bleeding, so a couple of instances where you might see bleeding during pregnancy. Some bleeding is normal, let me say. Large amounts, especially of bright red blood, is not normal. Small amounts or spotting can be normal, but if the pregnant patient has any concerns or they're not sure, definitely better to be evaluated. Rather be safe than sorry, especially if that bleeding is accompanied with abdominal pain. If it's painless bleeding, then we'll address that in just a second, what that could potentially mean. So looking at ectopic pregnancies, this is one example of a time when you could see some bleeding. And so when the embryo develops outside of the uterus, most often in the fallopian tubes, then we call that an ectopic pregnancy. Now, it can develop anywhere inside of that, from the ovary down to the fallopian tube, all the way into the uterus. I have heard of some very rare cases of the egg actually moving out of the fallopian tube, free floating into the abdominal area, and a fetus forming outside of the uterus and being able to carry to term, but that would be a very unique situation. If this egg is growing inside of the fallopian tube, then it is not going to be able to be carried. As you can see, the fallopian tube cannot continue to expand to accommodate that growing fetus. And so, unfortunately, this could be life-threatening for both the mom and the baby. So the leading cause of maternal death in the first trimester is internal hemorrhage following rupture of an ectopic pregnancy. So some clues here that we want to look at are sudden severe pain with a missed menstrual cycle, And especially if that pain is unilateral, meaning it's on one side. Okay, so she's of childbearing age, past puberty, and she has a missed menstrual cycle or suspects that she might be pregnant, or maybe even has had a positive pregnancy test, because up to that point it have been presenting normally. And now, if they are complaining of sudden, severe onset of unilateral pain most of the time, that should lead you to believe that this might be an ectopic pregnancy. And again, there could be some bleeding from this as well. And so that patient is going to need to be seen at the hospital. Again, the pregnancy is not going to be viable, and the goal here is to save the tube so that the mom could continue to have normal ovulation and potentially carry another child, but that baby would not be able to be viable. If the tube has not ruptured yet, then there are medications that can be given to help dissolve the fetus and all of the tissue particles there without surgery. But if the tube has ruptured, then the mom will likely need surgery. Other hemorrhages that can happen from the vagina, anytime that this is happening before labor, it can be very serious. So this may be a sign of a spontaneous abortion or a miscarriage. So spontaneous abortion is another term that we can use for miscarriage. Most of the time when we hear abortion, we think about intentional abortions, and that is one possible way of the pregnancy ending. But when we hear spontaneous abortion, that is a miscarriage. So there are two other times that we could see bleeding. That's abruptio placenta and placenta previa. I will get into those in just a second. Specifically relating back to the miscarriage, usually this pain will be on both sides. So whereas we said the ectopic pregnancy was unilateral, the pain of a miscarriage is generally bilateral on both sides, lower quadrant, and it feels like contractions, or if they don't know what contractions feel like, just really bad cramping. The worst menstrual cramps of their life. That's kind of how you would describe this. And again, bleeding. Now, with abruptio placenta and placenta previa, these two are going to be what are potentially life-threatening bleeds that we're going to be on the lookout for. So abruptio placenta is when the placenta separates prematurely from the wall of the uterus, and this could happen because of trauma like a fall, an assault, a car accident. And then placenta previa is where the placenta develops over and covers the cervix. And so as we mentioned previously, that placenta can develop over the cervix, which is a life threat. So these are the two examples. What you see here on the left is abruptio placenta, and so the placenta grew in the correct place, but because of some type of trauma, you have a severe pain as this placenta separates from the uterine wall, and there might be a small amount of dark red blood, if there is any bleeding at all. So that blood has a long way to travel, all right? It has to go all the way around the uterine wall to be expelled, and so it's not going to be really fresh. So if there is any bleeding at all, it will likely be a dark brown, and it might be just a little bit, and there might be none. But that severe pain following a traumatic event, no matter how serious you feel it may be, could be abruptio placenta. Now, what's happening here is this placenta is left off of the uterine wall, is that the baby is no longer getting an adequate supply of oxygen because that placenta has been detached and is not getting the oxygen from the mom. So it's a life threat really for the baby, and that baby needs to be delivered as soon as possible, most likely via C-section, as the mom is probably not in labor. So rapid transport is going to be your best bet here. Now on the right hand side, that's placenta previa. And so this is where the placenta develops over top of the cervix. And so the blood here will be a lot, and it will be bright red because it's very fresh. I want you to think about as if the cervix dilating is kind of like peeling the scab off of a wound. And so the blood is starting to come out of the cervix as it continues to dilate. Now, the mom might not be in labor. This might happen earlier on in the pregnancy because dilation and changes in the cervix can occur throughout the pregnancy. It doesn't have to just be related to delivery. But whenever you see this, we definitely want to have them checked out. So bright red bleeding that is painless, because this is not painful for the mom, painless bright red blood, that's a definite concern here for placenta previa. Now, it depends on how far along they are in their pregnancy. If they're still fairly early on, as the uterus continues to grow, the placenta could potentially move, and that could go up to the side, and they might be able to have a normal, healthy vaginal delivery. But if it doesn't, and this is towards the end of the pregnancy, likely they will have to have a C-section, because you cannot deliver the placenta first. It can take quite a long time to have a baby vaginally. And so that's a long time that oxygen supply would be cut off to the baby. So we definitely want to make sure that if we see that first, or if they know they have placenta previa and they should not be delivering in the field, that we are transporting rapidly to an appropriate facility, because this cannot be delivered in the field. So an abortion, we just talked about this term, but this would be passage of the fetus and the placenta before 20 weeks, and it could be spontaneous or induced, as we said. The other term for a spontaneous abortion is a miscarriage. An induced abortion is what you would historically think of when you think about the word abortion. The most serious complications for both are bleeding and infection. So the best that we can do for these patients are to treat for shock and transport promptly. When it is spontaneous, or even sometimes when it is induced, we definitely want to be really empathetic and also very comforting, providing emotional support to the mom. This is a very difficult time for them. Sometimes they could be quite far along when this is happening. It is still possible for the baby to be born, and we'll talk about fetal demise if they're a little bit further along. If it's before 20 weeks, it would be considered a spontaneous abortion or a miscarriage. If it's after 20 weeks, it would be considered a fetal demise, which would be if the baby were to pass at that point and no longer considered a miscarriage. But either way, definitely has the potential to be traumatic to the patient. And so we want to be really empathetic and sympathetic and provide a lot of emotional support to these patients. Looking at abuse, pregnant women unfortunately have an increased chance of being victims of domestic violence and abuse, and these abuse does increase the chance of a spontaneous abortion or miscarriage, potentially that abruptio placenta that we mentioned, and also premature delivery or low birth weight if the baby were to be born early. These women are at risk for bleeding, infection, and also uterine rupture. We want to be very carefully paying attention to the environment and looking for any signs of abuse as far as relationship between the patient and the abuser or the suspected abuser. Is the patient allowed to speak for themselves and answer questions? All of the same things that we would normally look for, especially with child abuse, we can look for here. If the abuser is not letting them answer questions and they're answering for them, the story just doesn't add up. If we see other signs of abuse, like varying degrees of bruises and things like that, we want to be really suspicious, try to talk to the patient in a private area away from the potential abuser if possible, and definitely let them know at the hospital what you suspect. Looking at substance abuse, the effects of addiction or drug use, alcohol use on the fetus include prematurity, meaning the baby is likely to be born early, and because of that have a low birth weight. They might have severe respiratory distress, or it could cause fetal death. So fetal alcohol syndrome describes the condition of infants born to women who have abused alcohol during their pregnancy. Generally, this occurs especially when the alcohol consumption occurs during the second and third trimesters especially. We want to be very cautious and protect our safety, looking for clues that we might be dealing with someone who is addicted, and then also after the baby is born, looking for the possibility that they might need immediate resuscitation, especially if the patient was utilizing narcotics or street drugs that the baby might be addicted to, that might be having withdrawal symptoms from, but also that the baby might be having respiratory depression because of those. And so we want to be really cautious here and look for the need for resuscitation for the baby. So I'm going to stop this portion of the video here, and I'll catch you guys in the next part.